Parkinson's disease. Parkinson's disease is a slow, progressive, degenerative neurological movement disorder associated with decreased levels of dopamine. It commonly affects men more than women, starting from the 50s. The cardinal signs of Parkinson's disease are tremors, rigidity, bradykinesia, echinacea, and postural instability. Autonomic symptoms include excessive sweating, drooling, paroxysmal flushing, constipation, orthostatic hypotension, gastric and urinary retention, and sexual dysfunction. Dysphonia and dysphagia is also present. Depression, anxiety, dementia, delirium, and hallucinations may also be seen. Pathophysiology of Parkinson's disease. There is a decrease in the level of the neurotransmitter dopamine, which is inhibitory and is present in the substantia nigra of the basal ganglia. This leads to depletion of the dopamine levels. This in turn results in more excitatory neurotransmitters, or the acetylcholine, than the dopamine, which is inhibitory. So this leads to an imbalance that affects the voluntary movement. The main signs are tremors, rigidity, bradykinesia, and postural changes. The symptoms do not appear until about 80% of the dopamine levels are decreased. Clinical manifestations. Postural instability is common. Patients may complain of being unable to stop themselves from going forward, or in other words, propulsion, or backwards, which is retropulsion. Assessment of postural instability includes the pull test, in which the examiner stands behind the patient and gives a tug backwards on the shoulder, which causes the patient to lose their balance and fall backwards. Tremor is often the first sign of Parkinson's disease. It is so minimal initially that only the patient may notice it. It is more prominent at rest and is aggravated by emotional stress or increased concentration. This tremor can affect handwriting, causing it to trail off, particularly towards the end of the words. Hand tremor is most common. It is described as pill rolling because the thumb and forefingers appear to move in a rotatory fashion. Tremors can also involve the diaphragm, tongue, lips, and jaw. Rigidity is increased resistance to passive motion when limbs are moved through range of motion. It has a jerky quality when the joint is moved. Rigidity is similar to the intermittent catches in the movement of a cogwheel. Bradykinesia is slowing down in the initiation and execution of movement. It is evident in the loss of autonomic movements like blinking, one-side swinging of arms while walking, stoop posture, masked face or expressionless face, drooling of saliva, and shuffling gait, or in other words, called festination, that are characteristic of Parkinson's disease. Akathisia is restlessness, an urgent need to move forward, and agitation. Bradykinesia is very slow voluntary movements and speech. Dyskinesia is an impaired ability to execute voluntary movements. Non-motor manifestations include depression, anxiety, fatigue, pain, constipation, sleep problems, and short-term memory loss. Treatment for Parkinson's disease. The treatment is directed towards controlling symptoms and maintaining functional independence. First drug is levodopa-carbidopa or Sinemet. Levodopa with carbidopa is often the first drug used in the treatment of Parkinson's disease. Levodopa is a precursor of dopamine and crosses the blood-brain barrier. It is converted to dopamine in the basal ganglia, and carbidopa inhibits an enzyme that breaks down the levodopa before it reaches the brain. The net result of the combination of the levodopa and carbidopa is that more levodopa becomes available and reaches the brain, and therefore less drug is needed. However, levodopa has many side effects and drug interactions. Prolonged use can often result in dyskinesias and off-on periods when the medication will unpredictably stop working. Therefore, monitor for the signs of dyskinesia, inform patient and caregiver that effects may be delayed for several weeks or months when initially started on this drug. Instruct the patient to report any uncontrolled movement of the face, eyelids, mouth, tongue, arms, hands, or legs, mental changes, palpitations, difficulty swallowing, and urinating. The next drug is modafinil, which is a CNS stimulant. The purpose of modafinil is to improve wakefulness in patients with excessive daytime drowsiness. Adverse effects include suicidal ideation, GI disturbances, and rash. This is administered as a single dose in the morning. Patient and family teaching is necessary. Instruct patient to take medication as directed. Medication may impair judgment. Advise patient to use caution when driving or during other activities requiring alertness. Encourage patient and family to be alert for emergence of anxiety, agitation, panic attacks, insomnia, irritability, hostility, impulsivity, akathisia, hypomania, mania, worsening of depression and suicidal ideation, especially during early antidepressant therapy. Assess symptoms on a day-to-day basis as changes may be abrupt. If these symptoms occur, they are to notify the healthcare professional. Advise patient to notify healthcare professional immediately if any rash or symptoms of anaphylaxis may occur, which may occur after a few weeks or months on the therapy. Next, surgical procedures. Stereotactic procedures like thalamotomy and pallidotomy are available but are very rarely used. Deep brain stimulator or DBS has been shown to improve motor function and reduce dyskinesia and medication usage. It involves surgical implantation of an electrode into the brain. Stimulation increases the release of dopamine release. Patients, those who responded to levodopa but are impaired by dyskinesias and disabled by tremors and have had the disease for 5 years are the ones eligible for this procedure. Neural transplantation. Ongoing research is exploring transplantation of porcine neuronal cells, human fetal cells, and stem cells to replace the degenerated striatal cells. And this is ongoing and seems to be promising. Care of the patient with Parkinson's disease starts with the assessment. Focus on the degree of disability and function of the patient, including ADLs, IADLs, and cognitive function. ADLs are the basic self-care tasks, and the six ADLs are eating, bathing, dressing, toileting, mobility, and grooming. The instrumental ADLs or IADLs are slightly more complex skills like using the telephone, shopping, preparing meals, housekeeping, taking medications, etc. Assessment regarding the different medications the patients are on and the responses to medications is done. Emotional responses and individual coping skills is assessed. Family processes and coping of the family is important. Home care and educational needs, the amount of support that is there, social support, and other spiritual support systems that are available to the patient, and fall risk assessment within the house, within the home, to prevent falls, the adjustments that are needed, all those home assessment is also done to prevent the risk of falling. The diagnosis for Parkinson's disease patient include impaired physical mobility and risk for activity intolerance, disturbed thought processes, self-care deficit, imbalanced nutrition, constipation, impaired verbal communication, ineffective coping and compromised family coping, deficient knowledge, and risk for injury. The major goals includes improved functional mobility, maintaining independence in ADLs, achieving adequate bowel elimination, attaining and maintaining acceptable nutritional status, achieving effective communication, and developing positive individual and family coping skills. Interventions related to improved mobility include daily program of exercise. A daily program of daily exercise or daily program of exercise will increase muscle strength, improve coordination and dexterity, reduce muscular rigidity, and prevent contractures that occur when muscles are not used. Encourage patients to ambulate frequently and avoid prolonged sitting. Walking, riding a stationary bicycle, swimming and gardening helps maintain the joint mobility. Have patient rock back and forth to initiate movement and avoid sitting in deep, soft chairs. Use firm chairs that rock for ease in standing. Stretching, which is stretch, hold, relax, and range of motion exercises promote joint flexibility. Postural exercises are important to counter stooped posture. Assist the client in maintaining posture by teaching the patient to hold hands behind the back, which helps keeps neck and spine straight, and lie prone periodically without a pillow. Consultation with physical therapy for safe exercise plans are effective for delaying the progress of the disease. Warm baths and massage, along with passive and active exercises, will help relax muscles and relieve pain. Walking techniques for safety and balance to offset shuffling gait, or in other words, festinations, and leaning forward. Concentrate on walking erect to watch the horizon. Use a wide-based gait. Conscious effort to swing both arms equally. Raise the feet while walking. Use a heel-toe placement of the feet with long strides. Practice walking to a marching music to provide a sensory reinforcement. Perform breathing exercises while walking to provide additional movement of rib cage and improve aeration of the lungs. Encourage frequent rest periods in between activities. Use of assistive devices like cane or a walker, front wheel walker is helpful. Consider using Velcro instead of buttons and slip-on shoes instead of those with ties. Enhancing self-care ability. Encourage, educate, and support independence. Environmental modifications may be necessary to compensate for functional disabilities. Use of assistive and adaptive devices like a hospital bed at home with side rails, an overbed frame with a trapeze, or a rope tied to the foot of the bed can provide assistance in pulling up without help. Consultation with occupational therapy to evaluate patients' need at home and to make recommendations regarding adaptive devices is planned. Improving bowel elimination. Constipation is a frequent problem due to weakness of the muscles used in defecation, lack of exercise, inadequate fluid intake, drooling, and side effects from medications. Establishing regular bowel routines will help. Consciously increase the fluid intake. Eat foods with moderate fiber content. Avoid laxatives. Use raised toilet seats to help patients move from a standing to a sitting position. Improving nutrition. Patients have difficulty maintaining weight. Eating becomes a slow process requiring concentration due to dry mouth, difficulty chewing and swallowing. They are at risk for aspiration due to impaired swallowing and accumulation of saliva. They may be unaware that they are aspirating and can subsequently develop bronchopneumonia. Supplemental feeding, increased calorie intake, allow time when they eat, maintain aspiration precautions, monitor weight weekly. And again, it's important to check the weight on the same day of the week, same time, same weighing scale, and the same amount of clothes. Nasogastric tube or PEG feeds NG feeds or PEG feeds may be necessary in later stages. Enhancing swallowing. Swallowing difficulties and choking are common in these patients. Semi-solid diet with thickened fluids are easier to swallow than solids and liquids. A high protein, high calorie, and high fiber diet divided into small frequent meals with at least 2000 ml per day is promoted. Encourage mindful swallowing by thinking through the swallowing sequence. The patient is instructed to place the food on the tongue, close the lips and teeth, lift the tongue up and then back and swallow. The patient is encouraged to chew the food on one side of the mouth and then on the other. Encourage patient to have an upright position and make a conscious effort to swallow. Massaging facial and neck muscles before meals may be helpful. Use of assistive devices. An electric warming tray keeps the food hot and allows patient to rest during the prolonged time that it may take to eat. Special utensils to assist with mealtime, like stabilized plates, non-spill cup, built-up handles, are useful. Occupational therapy consults also may be helpful. Improving communication. Speech disorders are present in most patients with Parkinson's disease. The low-pitched, monotonous, soft speech requires that they make a conscious and mindful effort to speak slowly with deliberate attention to what they're saying. The patient is reminded to face the listener and exaggerate the pronunciation of words, speak in short sentences, take a few deep breaths before speaking. Speech therapists may be helpful in designing speech improvement exercises and assist the family to use an effective method of communication. Use of electronic amplifier is also helpful if the patient has difficulty being heard. Support of coping. Patients can become socially and emotionally withdrawn. Patients often feel embarrassed, apathetic, inadequate, bored, and lonely. Assist the patient in setting achievable realistic goals, encourage socialization, recreation, and independence, plan programs of activity, and rest. Support groups and referral to supportive services may be helpful, like counselors, social workers, and home care.